Welcome to this explainer, everybody. I am so thrilled you're joining me today because we are going to break down the exact textbook clinical flow of heart failure. Whether you're prepping for your board exams, gearing up for ward rounds, or you just want to totally solidify your cardiovascular knowledge, this explainer is designed to get you absolutely ready. We are going straight from the underlying path of physiology directly into best clinical practice. Okay, let's dive right into this. Here is our roadmap for today. First, defining heart failure. Second, classification and causes. Third, left versus right-sided symptoms. Fourth, core investigations. And finally, the 4 treatment pillars.
All right, Section 1, defining heart failure.
Before we can even think about treating a patient, we have to start by isolating the core mechanical failure of the pump itself. You see, heart failure isn't just one single disease. It's a clinical syndrome. It happens because of either a structural or a functional cardiac abnormality. And that abnormality ultimately leads to one of 2 very distinct mechanical failures. Either the heart has an impaired ability to properly fill up with blood, or it has an impaired ability to eject that blood forward. Filling or ejecting. Keep those 2 concepts front and center in your mind, because they literally dictate everything else we're about to discuss.
Moving right along to Section 2, classification and causes.
So how we categorize this mechanical failure dictates our entire diagnostic and treatment pathway. The crucial piece of the puzzle is how we separate these filling and ejecting issues, and we do that using ejection fraction, or EF. On the left side here, we have HFrEF, which stands for heart failure with reduced ejection fraction. This is defined as an EF of 40% or less. The pump is weak, it can't eject properly, and the most common cause by far is ischemic heart disease. Now on the right, we have HFpF, heart failure with preserved ejection fraction, defined as an EF of 50% or more. Here, the pump actually squeezes just fine, but it's way too stiff to fill properly. The most common culprit? Good old chronic hypertension.
But hey, biology is rarely purely black and white, right? That is exactly why we recognize a gray area. HFmrEF, or heart failure with mid-range ejection fraction. This sits right there between 41 and 49%. It often represents an overlap or a transitional state for patients moving between the preserved and reduced categories. Spotting this is absolutely vital for complete clinical accuracy.
Let's build out the picture for reduced ejection fraction a bit more. Beyond ischemic heart disease, what else actually causes a weak, floppy pump? When you're on the wards, you really need to watch out for dilated cardiomyopathy, which can be idiopathic, genetic, or even toxic. You also have post-myocarditis, severe valvular disease like aortic or mitral dysfunction, alcoholic cardiomyopathy, and peripartum cardiomyopathy. All of these result in that hallmark weak squeeze and an EF of 40% or less.
Conversely, what about the stiff, preserved ejection fraction pump? It's a totally different profile. We see atrial fibrillation, diabetes, obesity, and honestly, simply being elderly. But importantly, you also have to think about infiltrative diseases, things like amyloidosis and sarcoidosis. You've also got hypertrophic cardiomyopathy and constrictive pericarditis. These etiologies physically restrict the heart's ability to relax and fill with blood.
Okay, let's hit Section 3, left versus right-sided symptoms.
Now that we understand why the pump fails, let's look at the physiological ripple effects. How does this failing pump actually manifest in the patient sitting in front of you? Well, think of heart failure like a massive traffic jam. If the left side of the heart fails, the traffic backs up into the lungs. Your patient is going to present with dyspnea on exertion, orthopnea when lying flat, paroxysmal nocturnal dyspnea or PND, and maybe even a cough with pink frothy sputum if things are really acute. On exam, you're going to hear basal crackles and an S3 gallop, which screams volume overload. Now, if the right side of the heart fails, the traffic backs up into the systemic venous system. You'll see peripheral pitting edema, ascites in the abdomen, an enlarged liver or hepatomegaly, elevated JVP in the neck, and hepatojugular reflux.
Once we identify all these symptoms, we don't just write them down and move on, we grade them. We use the NYHA Class 1 to 4 system. This lets us assess the functional severity of the patient's heart failure, going from Class 1, where they have 0 limitations with ordinary physical activity, all the way up to Class 4, where they have terrible symptoms even when they're just resting. This grading isn't just for show, it is going to directly influence our treatment choices in a few minutes.
Which brings us to Section 4, core investigations and diagnosis.
Picture this. A patient comes in breathless and swollen. What exactly are we looking for in our clinical workup to confirm this syndrome? We start with the biomarkers, NT-proBNP, or BNP. I want you to burn these cutoff numbers into your brain right now. If the patient is in normal sinus rhythm, we're looking for a level of 300 picograms per milliliter or higher. But if they are in atrial fibrillation, that threshold jumps way up to 900 or higher. The real superpower of this test is its high sensitivity. It's fantastic for ruling out heart failure. If the numbers are below those thresholds, the shortness of breath is almost certainly coming from somewhere else.
Now, if the BNP is elevated, we launch the core diagnostic workup. Echocardiography is the undisputed king here. It is exactly how we determine the ejection fraction, chamber sizes, valvular competence, diastolic function, and right ventricular function. We also need an ECG to check for left ventricular hypertrophy, ischemia, AFib, or even low voltage, which might be a sneaky hint for amyloidosis. A chest X-ray will show us cardiogoly, those classic curly B lines of pulmonary venous congestion and pleural effusions. Finally, routine bloods are a must, checking full blood count, urea and electrolytes, creatinine, liver, and thyroid function.
Actually, pause for a second. Here is a massive clinical pearl for you. Heart failure patients are incredibly commonly iron deficient. And no, that's not just some minor trivial detail. It actively worsens their fatigue and their overall outcomes. As part of your routine bloods, you absolutely must check iron studies, specifically ferritin and TFSET. It's a highly testable fact and a really crucial part of holistic patient care.
All right, the final stretch, Section 5, the 4 treatment pillars. This is where we focus entirely on the ESC 2025 evidence-based guidelines to actually manage and treat these patients. For our patients with reduced ejection fraction in NYHA classes 2 through 4, we deploy the 4 pillars. The goal here isn't just to make them feel a little better. These 4 drug classes actively reduce mortality. They literally save lives. Pillar 1, an ACE inhibitor, ARB, or an ARNI like sacubitril/valsartan, which is honestly preferred if the patient is stable. Pillar 2, a beta blocker like bisoprolol or carvedilol, which must be up-titrated super slowly. Pillar 3, an MRA like spironolactone, but check those labs first. You have to ensure their eGFR is over 30 and their potassium is safely below 5.0. And finally, Pillar 4, the SGLT2 inhibitors like dapagliflozin or empagliflozin, and you give these regardless of whether the patient has diabetes or not.
But wait, while those 4 pillars are working their magic in the background to remodel the heart and save the patient's life, what do we do about the fluid overload making them totally miserable today? That's where symptom control comes in. We add diuretics, typically furosemide, for congestion, and this applies to both HFEF and HFpEF. Now, to be clear, diuretics don't fix the underlying pump failure, but they dry the lungs out and bring immediate, much-needed symptomatic relief.
Now, speaking of HFpEF, the preserved ejection fraction, the management landscape here has completely shifted recently. Historically, we had very little to offer these patients besides diuretics. But recently, SGLT2 inhibitors, specifically empagliflozin, are now officially recommended for HFpEF as well. It's a real game changer. Alongside the SGLT2 inhibitor and diuretics for congestion, the rest of the management relies on aggressively treating their comorbidities, managing that hypertension, controlling the atrial fibrillation, and addressing obesity.
Finally, for patients whose ejection fraction remains severely reduced at 35% or less, even with optimal medical therapy, we look to device therapy. We use an ICD, or implantable cardioverter defibrillator, for patients in NYHA 2 or 3 to shock them out of fatal arrhythmias. On the flip side, if the patient has a left bundle branch block with a wide QRS complex of 150 milliseconds or more, it means the electrical signals of the heart are uncoordinated. In that specific case, we use CRT, or cardiac resynchronization therapy, to electrically pace and resynchronize the ventricles, improving that mechanical squeeze.
So, that covers the whole shebang, the entire textbook flow of heart failure, from the underlying mechanics straight through to the ESC 2025 guidelines. But I want to leave you with this final provocative thought. With SGLT2 inhibitors now proving so effective and spanning across the entire spectrum of both reduced and preserved ejection fraction, are we finally closing in on a true universal therapy for the failing heart? It is a genuinely fascinating time in cardiology. Thank you so much for joining me for this explainer. Make sure you keep reviewing these concepts, and I will see you on the wards.